So this will be a lunch seminar series with 4 lunches. Each lunch there will be 2 presentations on topics where we have identified areas of particular interest to us at the IT department. And today there will be 2 presentations, one by Dag Nyholm and one by Maria Hägglund. And the format will be as follows. There will be a 20-minute presentation by Dag, and then 5 minutes for questions, and then similar then for Maria. And there will be a dissertation in this room after the lunch, so we need to stick to the time plan. But with that, I leave the floor to Dag Nyholm for the first presentation.
So thank you very much. So I'm a neurologist working at the hospital here at Akademiska. So I meet patients with movement disorders, for example. And so first I will give a lecture on movement disorders and what you can see when you work with these patients. And then we'll talk about the possible technical solutions for example, detecting their movement disorders. But first of all, what is a movement disorder? Well, it's a dysfunction of the basal ganglia, deep inside of the brain. Sometimes you can call these extrapyramidal disorders to separate them from motor neuron disorders, where, for example, a stroke causes a damage to the motor neurons, which causes a weakness in one arm, for example. This is not the case with movement disorders. Movement disorders are disorders regarding control of the movements. So not the muscle strength itself, but other aspects of movement. And then you can have hyperkinetic disorders, for example, tremor, which is shaking, and other things like that. And you can also have hypokinetic disorders, where Parkinsonism is the most common of those ones, like Parkinson's disease. And this is Parkinson's disease, tremor, shaking, bradykinesia, which is slowness of movement. So all their body movements are slower than usual. Rigidity is what you can feel as a muscle tone increase. And postural instability has to do with balance and the control of the balance. But there are also more symptoms. You can find many different motor symptoms, and this is interesting when we talk about sensors and measuring motor symptoms. But there are also non-motor symptoms in this disease that are not as easy to detect or to examine, like pain, for example, sleep disturbance, and so on. So it's quite complex. There's in all these patients there's a mix of different symptoms, really, which makes you think that maybe Parkinson's disease is not one disease, but rather a syndrome of several different diseases. You might know that there is a dopaminergic deficiency in the brain, and as a pathologist, you can look at the specific nerve cells that are actually lacking. So a specific type of nerve cell dies, and you get the symptoms simply. But it's not very simple, because you can try to draw some sketches of the basal ganglia functions, and you see it's very complicated with, at least I think it's very complicated. Maybe you think it's easy, but many different connections with different parts of the brain. And it's also quite, as a clinician, when you see a patient in front of you, it's quite difficult to know, is this really Parkinson's disease? It's a clinical diagnosis, so we can just look at the patient and describe the type of movement disorder. But you see PD, that's Parkinson's disease. It's overlapping with some similar diseases to some extent. And there are similarities with Alzheimer's disease, which is a dementia disorder, but that can also have some movement disorders in it. So it's quite complex, and there's a large spectrum of different similar disorders. Arvid Carlsson got the Nobel Prize 16 years ago because in the 50s he blocked dopamine in rabbits and saw that they were moving like Parkinson patients. they had the bradykinesia, the slowness of their movements. So that was an important, this discovery was very, very important. Dopamine is involved in motor circuits in the brain, but there are also several other circuits concerning, for example, associations, cognitive function, and the limbic circuits regarding, for example, depression, anxiety, and things like that. So just trying to show you that this is quite complex. And when we see that Parkinson's disease starts at time 0 there, we can see the motor symptoms and describe these. But the disease process has probably started several years before we can see the motor symptoms. So actually these dopamine cells are dying probably for decades until we can see it in terms of motor symptoms. We use medication to treat and to try to restore the dopaminergic stimulation. There's a lack of dopamine. We need to add dopamine in some way. We can do it with levodopa, L-dopa, or with the dopamine agonist, different kinds of drugs. And L-dopa, maybe you've seen the movie Awakenings, Uppvaknanden in Swedish, where some patients in the late 60s got levodopa for the first time and kind of woke up from a state where they were quite immobile and in bed all the time and so on. But suddenly they could rise and move, like Robert De Niro here in the movie. And L-dopa is something very simple. It's an amino acid, you know, the amino acid phenylalanine. I don't know the English word. Phenylalanine, perhaps. And this is so this is actually a naturally occurring amino acid, which when it enters the body can convert to dopamine. So it's very simple, but it was a great discovery and has helped millions of people since then. Because without medication, you would die from Parkinson's disease after 10 to 15 years because you get completely immobile. And then you're in a bed and you swallow the food into the lungs and get pneumonias and things like that. So it's really an amazing discovery. Now I will show you some videos of patients. And this is a patient who was 49 years old here. He had Parkinson's disease for 14 years, and once upon a time he gave me the allowance to show this in educational purposes. So we can see here, you can see fairly well that he has tremor, the shaking of his hands. You can see that his facial expression is Parkinsonistic, slowness even of the facial muscles. And he is forward bent and very slow when he tries to do these arm movements. So this is typical Parkinson symptoms with tremor and the slowness of the movements, and he feels rigid in his arms and legs. And when he tries to rise, which is quite soon, he's not able to do it. He can't rise from the chair really. You can see he's very slow. He tries even to move his leg with the help of his hand, but he can't do it. And even if we pull him up from the chair, he won't be able to walk at all. So he's in the worst situation, and if this would have been in the 60s, he would have been dead by this time, actually. Now he's actually in the middle of in between two doses. So when we look at him 1 hour later, the situation is quite different, and it's simply from levodopa, L-dopa treatment. So you can see that he's more straight in his body position, and he can do these arm movements much more normally, and actually quite normal, I would say. And then I usually ask my students, do you think that he can rise now and walk? And some dare to guess, yes, I think so. And this is what happens. He rises without any difficulties, and he walks quite normally, and you can't really see that he has Parkinson's disease now. His arm swing is nice, and his step length is good. So he walks quite normally, simply after adding levodopa. And the problem is that when you get too much levodopa, you can get involuntary movement, so that you get too much movement, and it looks like this. Then he is in a state where he can move. He can do these arm movements, but there are lots of other movements adding, which makes it very difficult for him. He can rise and walk, as you can see, but with lots of other movements kind of superimposed onto the normal movements. And here he's in actually a drug trial where he got too much medication at this moment. So when we decrease the dose, he's normal again. And if we decrease the dose too much, he's back in that terrible Parkinson situation. And it's quite common that after perhaps 10 or 15 years of disease, you get fluctuating like this. So the red curve here is the concentration of levodopa, L-dopa in the blood when we measure that. And between each time point there is 20 minutes. So you can see that especially in the afternoon when the concentration rises, the patient gets more dyskinetic, these involuntary movements, and suddenly they stop. So from being mobile but with involuntary movements, suddenly everything stops. It's like pushing a button, like an on-off button, and therefore this is called on-off fluctuations. And so the patient is Parkinsonistic for a while, and then the next dose comes in, and after 20 minutes later, the patient turns hyperkinetic again, and is moving around, and then again falls when the drug concentration has become low again. So this is a very complicated situation for patients in advanced stages of the disease. And this is a sketch to show that there are different stages of the disease. In the beginning, everything is green, normal mobility. It doesn't matter if these drug fluctuations are fluctuating. The patients are quite stable in their motor function anyway, but as the disease progresses, they get these wearing off situations where the drug doesn't work for a while, and then they eventually might come into this stage where they have the red boxes here are hyperkinesias, and the blue ones are Parkinsonism. So they fluctuate frequently between different motor states, which is very troublesome for these patients. So therefore, we have developed different treatment options, and this one is actually from Uppsala and was marketed in Sweden this year as the first country in the world. It's dose dispenser that contains small minor tablets of levodopa, so that you can fine-tune the dosage. And there's a smartphone screen where you can press, and you can increase or decrease the dose, and you can do anything you like almost, and you can also report your symptoms if you like. Then there are two different pump systems for, well, it doesn't matter what kind of medication, but both are Parkinson medications. And this one is from actually also developed here in Uppsala. And then there is brain surgery with deep brain stimulation, where you can see that you put electrodes into the brain to one of these three stimulation points, and then you have a battery which is inside underneath the skin, which gives a so-called deep brain stimulation. And all these methods are good at treating these fluctuations. So this is actually another movie which shows ongoing DBS surgery. And this is a specific situation where the patient is awake in the operation room, and this is the neurologist coming in and testing the patient. And this is not a patient with Parkinson's disease. It could have been, but this situation is a patient who has another movement disorder called essential tremor, which means that he shakes when he's trying to write, for example, and it has become impossible for him to eat or drink because he spills everything and he can't really manage. He has written akademiska and drawn a square, and you can see that there's a lot of shaking. So now the patient is in the operation room, the neurosurgeons are behind the head of the patient, and they have drilled small holes into the top of the skull, and they will soon place the electrodes there. But first there's some testing to see what the patient looks like before the electrodes are in place. So here the patient tries to drink water. To grab the glass of water is very difficult. You see immediate shaking, so it's impossible to really do this. But now the electrode is in place, and immediately there is a reduction of the tremor. So he can actually now move the glass towards it, which he probably hasn't been able to do in several years. And he tries again because he's so happy that he can do this simple movement, but previously impossible. And finally he tries to write again. It's perhaps not the most convenient place to write when you're in the operation room, and the head is fixed in a frame. But you can probably see here soon that there is a difference. There is much more less of the shaking when he tries to write and draw a square. So now we get into the technical aspects, I mean the market of technical devices and sensors is really exploding. So this is my face when we, together with Alexander Medvedev and his group, are testing eye tracking. So we can examine the eye movements in a very with very high resolution. And this is a type of patient diary where the patient can answer questions about how they feel for the moment at the moment, and also, for example, draw spirals, where we have learned, where machines have learned how to interpret these spirals and kind of tell us what kind of motor state the patient is in. This is something that we use, so this is research, but this is something that we use in clinical practice now. You can, maybe you know what it is, accelerometer or gyroscope or something like that. That can measure the patient's kind of mobility, so it can detect both slow movements and these involuntary movements. So this is something that we really use nowadays. This is an example of telemedicine, where we can, as a doctor, you can talk to a patient or who is at home, or we can also talk to colleagues and discuss patients and so on. And then there are other aspects with sensors of different kinds to measure mobility and things like that. This is actually a researcher and a patient, and I heard now that Maria, the next speaker here, is the main supervisor of this person. She's called Sara Riggare, and she has Parkinson's disease, and here it says in Swedish that the modern patients are challenging. So it's like healthcare versus self-care. And this is a very nice picture that Sara has made. It consists of 8,765 dots, which is the hours of the year. And one of these dots is red. So that's, as it says here, the 1 hour where the patient is in the neurological healthcare, and the rest of the time is self-care. So this is her research project, so it's quite interesting. Maybe we can ask Maria more about it later on. Or visit the dissertation, perhaps next year or so, yeah. So these are just some examples of research that we have done. I think we were the first to use a wireless, which was very specific then in 2003, something that was wireless. It's not anything special about that today, but it was 13 years ago, with data capture of both subjective and objective information from the patients. Well, this is also further research on that idea, together with people from computer engineering in Dalarna, Högskolan Dalarna. And this is an example of the work we have done together with Alexander and his group with eye tracking. So ongoing research now regarding movement disorders. We have some PET MRI studies, which are mainly focused on diagnostics then, which is new and interesting, a bit fancy perhaps. Then we have an ongoing project that's called Music Project, where also Alexander and his group are involved. And together with, for example, Sahlgrenska in Gothenburg, we do some studies on sensors and movements, and also in relation to drug concentrations, which is quite interesting. So it's ongoing work there. Regarding DBS surgery, we have some imaging studies ongoing, and together with symptom evaluation, for example, with spiral drawing and other similar things. And I have a PhD student who is connected to pharmacometry at BMC, so she does some pharmacokinetic and dynamic modeling. Together with the guys in Dalarna, we do some levodopa titration algorithms, so a mathematical aspect of doses and fine-tuning. There is a national Parkinson's disease register where we can do register studies soon, probably. It's quite recently started, so there will be more from that. And there are also ongoing things on. So the future challenges, this is my last slide, is that we need portable systems for example, sensors. This is actually, maybe you can't see it, but this is Alexander and Ruben, who's there, with a not so portable system for eye tracking. It's quite heavy and large. So this is one of the future challenges, to get smaller devices and to involve them in the patient's daily life. We need frequent measurements because, as you saw before, they are fluctuating between different motor states. We have to capture all this, and this is a challenge. It should be usable for the patient, so that you don't have to carry around things like this and do frequent measurements that are time-consuming. So the patient's perspective is important, to ask them what is interesting and important for them. So to fine-tune and individualize treatment, that's the main goal for the future. So that was my 20 minutes. Thank you. So maybe we have time for questions while Maria gets here, or what do you say?
Today, software and algorithms are dominating solutions. At the same time, there are strategical needs for hardware to be implemented by software and algorithms. If you would tell, what is the hardware you are still awaiting?
Oh, pardon?
The killer app.
Yeah, the killer app, perhaps. Yeah, well, it should be something that you carry around. Like nowadays, we carry around the phones in our pockets. That's quite convenient, I think. Or watches, something that you could carry around.
Is it more motor kinetic, or is it measuring chemistry, biomarker? Should it be implantable or
Yeah. Of course, ideally, we would like to measure some chemical things as well, but that sounds almost much more difficult. So, but of course, yes, that would be nice.
Okay,
so, for example,
we can continue that discussion.
we can do that.
I'm looking forward to that.
Yeah.